Hey everybody, we're going to start the beginning of the end, if you will, for Unit 12-13. We've spent an awful lot of time talking about the different disorders, their various categories and subcategories, symptoms of each of them. So now we're going to start wrapping things up by talking about how it is that we go about attempting to treat all of those different kinds of mental disorders. And so much of this is going to come back to those original psychological approaches that you were presented with back in Unit 1. That was ultimately kind of how we presented disordered behavior to you initially, looking at it from the lens of each of those different perspectives and how they explain it. So it makes sense then that in order to wrap all this up, we're going to look at it again from that lens of how each of the different perspectives attempt to both explain the disordered behavior and then resolve the disordered behavior. In terms of history of treatment for those who have struggled with mental disorders, it's not a pretty one by any sense of the means. If you think back to when we introduced you to mental disorders and we talked about things like trephination, where they, burrowed holes into a person's skull to release the demonic evil spirits that had possessed those individuals. A lot of the time, the treatments that were out there for people who were, for all intents and purposes at that point, considered to be insane, were based on very irrational thought processes. And many of those patients were ultimately subjected to just awful kind of treatments that were they were dangerous, if not possibly life-threatening in some respects. But with individuals like Philippe Pinel, who created the medical model that we learned about at the beginning of the unit, he was in France, and Dorothea Dix, who was here in the United States, they both attempted to find far more humane ways to care for those who were mentally ill and struggling with an awful lot of disordered behavior. So when we talk about this issue of therapy, it's important to look at it from two different veins. You have psychotherapy, which is the therapist-patient connection, where you have a very emotionally charged interaction between these two individuals in a confiding fashion. Okay, how they go about attempting to do that psychotherapy is going to differ depending on the person's point of view. They might be a humanist and go with something like active listening, for example. They might be psychoanalytic. So the implementation of that psychotherapy might be different. It's also important to take a look at the issue of biomedical therapy, which has become ever more present in this day and age, where the use of drugs or other types of physiological procedures work to hit the patient's nervous system in some way, shape, or form. You've heard me make reference, for example, to SSRIs, which are used to help people with depression. It's going after their serotonin levels, and so they take drugs to help them boost their serotonin levels. So you could be from either of these circumstances where biomedical can be in and of itself its own therapy, but you could also have others, and we'll talk about those in a second. But it is important to recognize that the vast majority of trained therapists and psychologists and psychiatrists out there are going to go with an eclectic approach. Okay, they're going to use multiple or various different forms of techniques that are out there that they know of in order to address a person's unique situation. So that's an important piece to recognize, that they don't necessarily think that this is going to be like a one-size-fits-all kind of circumstance. So within the psychotherapy realm, we're going to look at 4 specific categories. And as I said at the beginning of this, it's all going to stem back to those different perspectives and how they explain behaviors. So ultimately, it will connect back to how they attempt to treat the disorders. So let's look at psychoanalytic first. This was the first formal psychotherapy out there to treat disordered behavior. Freud was one of the first guys to try to study it in the first place when he looked at the issue of what he called hysteria in women. Basically, what you would be familiar with it as now would be a type of anxiety disorder or depression. So this is going to be the first attempt that there is out there to try to help in terms of psychotherapy to help treat mental disorders. So the goal for a psychoanalytic perspective is to tap into the unconscious mind, which is where a lot of the repressed conflict and impulses of a sexual or aggressive nature have been pushed due to early childhood conflict and trauma. So the goal then is to tap into that, pull it up to the surface, and get the patient to be aware of those issues that they have so they can ultimately end up resolving them. When, according to this perspective, your energy that was devoted to kind of the id, ego, superego conflict is released, okay, then ultimately your anxiety will lessen. Your discomfort or your issues with regard to your disorder will go away. So basically what he's going to take a look at in terms of Freud's perspective is looking at how that ego is attempting to resolve the conflict between the id's demands and the superego's constraints, and whether you ultimately ended up resolving your libido in the appropriate manners. For example, when you were younger and you might have been fixated in like the oral stage or the anal stage or something along those lines, then you have the ability to get that tapped into and then ultimately end up fixing into that accordingly. A lot of the ways that was attempted to be done in Freud's time was through things like hypnosis. But Freud wasn't entirely happy with that whole scenario, so what he did was he developed free association. And you heard us make reference to this in Unit 10, but this was done to attempt to tap into that unconscious, access those areas of conflict where a person does not censor their thoughts in any way, shape, or form. So that way you can start to see some kind of negative associations that they have in order to be able to get those resolved and free the person from the struggles that they were facing. So a lot of times what would happen was the patient would lay on a couch and they would kind of face in the opposite direction from the therapist, and they would just start to talk about whatever came to mind. And then ultimately, your job as the psychoanalytic therapist was to provide inner meaning to what was being said, to give insight and interpretation to what was going on in the unconscious mind. Other examples of free association that were present, oftentimes they would attempt to tap into things in terms of dream analysis and interpretation. You also had circumstances of people doing word association where the therapist would say a word and then the patient would have to say whatever came to mind. And then that was ultimately another way to be able to tap into the unconscious. Now, in free association, the patient is sometimes going to, especially in the beginning when they're developing a relationship with the therapist, the patient might edit their thoughts. They might try to censor what it is that they have to say in order to resist feeling unpleasant emotions, okay, and to resist having to express those emotions. So what Freud called that was resistance. And he felt that it was quite important when it came to how it was that you attempted to evaluate a lot of that unconscious conflict-driven anxiety that created the disorder in the first place. And so what the goal was to get the patient to eventually open up and reveal those very deep recesses of their thoughts, to be more open and willing to share with the therapist. And so ultimately what would end up happening in Freud's opinion was that the patient would either develop positive or negative feelings toward the therapist. And he called this transference, okay? Where a person would, particularly when dealing with, let's say, conflicts that they had with their mother. Freud is very well known for his Oedipal complex structure, so let's take that one for example. Let's say you are a male patient, you are seeing Sigmund Freud, okay, you have started to open up a little bit, and so what happens is Freud believed that there can be a level of transference that occurs, and through this whole process where the patient might develop some kind of feeling toward the therapist because they are, pushing them to gain insight into these experiences and feelings that they're having, and life experiences that happened to them when they were very young that end up making them have an awful lot of struggles when they're an adult. It's possible for the person to develop positive transference, so they have very positive, kind of almost loving emotional responses to their therapist. Or they can develop a sense of negativity because that therapist is forcing them to ultimately face some things that they have attempted to repress and keep hidden from their conscious level of awareness for a really long period of time. Something else to consider with regard to that is an issue called countertransference, where Freud felt that it was possible in this very emotionally charged relationship that you have with your patient for the therapist to develop a form of transference, which was countertransference, that you, the therapist, could develop either positive or negative feelings toward your patient based off of what it was that they had shared with you, or how they interact with you. It's possible, for example, for you to fall in love with a patient because they are, kind of wandering through life, struggling an awful lot, but there you are, capable of being able to help them and gain them insight into their problems and their struggles. And so you start to develop a sense of feelings and attachment to them because you are someone that they can look to help them. It's also possible to develop negative feelings toward them as well, or hostile feelings. So countertransference is also a pretty important thing to keep in mind for yourself as well. Let's talk real fast about criticisms. Obviously the biggest one to an awful lot of psychologists out there, you can't scientifically prove it. It's very, 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 very hard to support it scientifically. On the flip side of that, it's also hard to disprove it because psychoanalytic perspective has been successful in some of the disorders out there to help treat it. So you can't really have, there's just not much data that can either disprove or support it one way or the other. And so that's a pretty big critique of it, just because within this field we do like data and evidence that supports the tracks that we are going to go in to treat our patients. The other thing to keep in mind that many argue is that psychoanalysis takes a really long time. It involves a lot of work with a therapist, a lot of work with a trained professional, and that means a lot of money. If you're a psychiatrist in this day and age, you could easily charge $150, $200 an hour for your services if you're in private practice. So it's a pretty lucrative situation for a therapist, so it would make sense that they would want to follow this line of thinking because ultimately then it gets them more money. And so they find them, you can find circumstances of people abusing that level of trust, if you will, when dealing with their patients. Now, current psychodynamic therapies are influenced by Freudian teachings. As you know, neo-Freudians, for example, adhere to some of what Freud emphasized and veered away from other components. For the psychodynamic therapists of the now, it's important to them to understand the symptoms and themes across a patient's very important relationships in their life. So they're going to do it in a face-to-face setting. It's not going to be a circumstance where you turn and you face away from the therapist. What they're going to do is they're going to look at you face-to-face and they're going to try to help you talk through things and help you to identify certain key threads throughout interactions that you've had with important people in your life to maybe have contributed to some of the struggles that you might have. Psychodynamic also takes a look at interpersonal psychotherapy, which is a variation of that initial psychodynamic therapy I just shared with you guys about it being very face-to-face. And ultimately what it does is it tries to focus on symptom relief, not overall change to personality, which is a little bit more of a prevalent circumstance right here. So what they're going to try to do is they're going to address symptoms at present rather than trying to get you to change major components of your overall personality that would require an awful lot of intensive time to be working with a therapist. So it's going to focus on things like a person feeling very socially isolated because of their struggles with anxiety or depression, for example. Relationships that an individual has found very unfulfilling and unsatisfying and the impact that's had on a person. Life transitions like divorce, loss of a loved one, that connects into with unresolved grief, which is listed down here as well. So these are all prevalent psychoanalytic or psychodynamic theories. Now let's switch gears. We're going to move into another predominantly lacking in scientific data component when we talk about humanism. Because as we've always mentioned about humanism, one of its greatest weaknesses is that it's just very hard to scientifically test that somebody is self-actualized, for example. But with humanistic theories, what they're going to try to do is they're going to try to help you get better by boosting your level of self-acceptance. Okay? getting you to recognize that you, as you sit in their office, are a good, wonderful, deserving person, flaws and all, imperfections and all. There are people that care about you, and so they're going to work to try to help you get a sense of self-awareness and fulfillment with yourself, and helping you to kind of grow toward that self-actualized component. Okay, so what you're going to have in here predominantly is going to be person-centered therapy, a la Carl Rogers. So he's coming back again. Excuse me. You learned about him many times in earlier units, but his strongest components to humanistic theory deal with being a fully functioning individual, having harmony between your true wishes and sense of identity and how you present yourself to other people, having unconditional positive regard for yourself. So Rogers is very client-centered in his therapy. Okay, this is where the therapist is going to listen to the patient in an insanely accepting, non-judgmental way. Okay, so there is no judgment that is going to be passed. Therapist isn't going to say, well, here's your problem, this is why you have these struggles. They're just going to listen to you, okay, and they're just going to let you vent, in a sense. To them, this is how they can address your problems, by helping you kind of build your self-esteem, by talking through your issues and your struggles and getting you to recognize that those struggles don't define you and that you are worthy of being accepted as you are. So within this field of client-centered therapy, you have active listening. The therapist is going to echo and restate and clarify what the patient is feeling. By doing that, what you do as a therapist is you acknowledge the person's feelings. So you're giving them a sense that, hey, you are listening, you hear what I have to say, you're not judging me in any way, you're not making me feel inferior for struggling with anxiety or depression or something else. And so the person feels accepted and acknowledged as they are, perfectly imperfect. Okay? So if, for example, you were sitting there working with Carl Rogers or any other kind of humanist, active listening would look something along the lines of this. Patient sits there, talks about how their anxiety is very overwhelming to them and they feel like it's something that people just don't understand, and they're kind of listing out things. And so what someone like Rogers would do in this therapy of active listening would say, all right, let me see if I'm picking up what you're putting out there and following what you have to say. You feel like your anxiety is something that people don't understand because to them, your feelings are exaggerated and out of proportion. You feel that they kind of belittle your experiences and they keep telling you, just get over it. But for you, that's just not a possible thing to happen. So as a result, you feel very isolated from that because you just feel like there isn't someone that you can speak to, that you can talk to help you feel less isolated. Is that what I'm hearing from you? So simply by just rewording or echoing, clarifying what that person, what that patient is saying to you, what you're providing to them is unconditional positive regard, that you are accepting of them and all of their struggles, and that they're allowed to be themselves and to speak freely in a warm environment. And so that can have a lot of very positive impact on those who seek that therapy out. It's very successful for people with depression and anxiety, as you heard me make reference to. All right, let's switch gears. And we're going to talk about behavioral therapy now. This is one that's going to look at the maladaptive actions that a disordered individual will take. Okay, so what they're going to do is they're going to apply learning principles, classical conditioning, for example, operant conditioning, for example, and they're going to use those to get rid of the undesirable behavior. So it's very common for you to see behavior therapy used to treat phobias or other types of anxiety disorders. Some sexual disorders that are prevalent there. Those we're not going to necessarily delve into because that's for college and something a little bit more in depth. But for these types of therapists, they're not going to delve super deep into things like inner causes for the behaviors. They're just going to focus on changing the actions themselves to help the person gain a sense of control over what it is that they're doing. So within classical conditioning techniques, you've got what we call counter conditioning. And so this is ultimately what you attempt to do is you try to break the response, the conditioned response an individual has to their conditioned stimulus, to ultimately the stimuli that triggers the unwanted, undesired behaviors. It's based on aspects of what's called exposure therapy. You've heard me make reference to that several times in class today. And it's also connected to something called aversive conditioning. This has been used, for example, to try to get people who are alcoholics to break that very self-defeating cycle of abuse and misuse of that drug. There are other different types of counter-conditioning measures that we can talk about in a little bit, but let's take a look at exposure therapy first, because this is one that is not a typical route that many will go, because it is very confrontational to an extent, but it does have some pretty significant merit in helping people with anxiety disorders in particular. Exposure therapy is exactly as it sounds. You expose the patient to the thing they fear and don't want to be exposed to, okay? So you force them to face their fear through repeated exposure. What happens is you begin to desensitize the individual to the item that evokes the fear. So, for example, if you are afraid of a spider, an exposure therapist is going to, they're going to attempt to force you to hold a tarantula. And you're going to do that possibly upwards of several times a session that you are working with them, until what happens is that anxiety-producing response eventually lessens and diminishes over time, because ultimately what happens is habituation. You've been presented with habituation before. You know, we become just repeatedly desensitized to certain things in our environment and in our lives, and that's because of habituation. Habit, things you do automatically without thinking, it stems from habituation. So that's what exposure therapists are going to attempt to do. It's possible for you to, for example, have a person be exposed to not the actual real object, but you could do it in a virtual reality kind of environment. You could make a person go through a simulation where they have to hold out their hand, and it's actually, it's a VR spider, not the real thing. But the brain can't tell the difference, because the same brain structure that's going to light up to activate your phobia is whether the spider is real or not. The same thing is going to light up whether it's virtual reality or not. So it's entirely possible for you to go through this kind of therapy and come out with a lessened response. Excuse me. This is just like the schizophrenia video. Once I hit 6 bell, I just have a hard time being able to lessen the yawning. Now, systematic desensitization is a little bit of a nicer, more gentler, kinder way of doing exposure therapy. Okay, what you're going to try to do is you're going to take a pleasant, relaxed state. So you're going to place the person in like a very nice, calming room, for example. And what you're going to attempt to do is gradually increase that person toward the anxiety-causing stimuli that they are afraid of, okay? And so you're going to teach them kind of behavioral techniques to be able to respond to that. So what a systematic desensitization focus is going to look at is they will tell you, okay, write out every kind of circumstance that you would be afraid of interacting with a spider, and then what they're going to do is they'll tell you to organize them in order. Like this is the most fearful kind of circumstance, and this is the least fearful. And they're going to start to try to work you toward that. So let's say, for example, that anytime you're presented with a picture of a spider that freaks you out, okay? So what they're going to do is they're going to place you in a calming environment. They're going to present you with a picture of a spider, okay? And so ultimately what they're going to do is they're going to, compel you to, through this, relaxing state, be able to hold a picture of a spider and look at it, okay? Then you've said, well, like seeing a real spider is that is very, very, very scary to me in person. That's the second one. So what they're going to do is they're going to bring out a real spider, and they're going to compel you to look at that spider in that very relaxed state, getting you to use coping techniques when presented with it, okay? And they're going to bring it closer and closer to you in physical proximity, that real life actual spider. Then you say, well, my big thing is that I can't handle touching a spider, okay? And so, what you're going to have to do is ultimately work toward being able to, through this systematic process, desensitizing yourself to the possibility of being able to hold a spider and not having an anxious or fearful response to it. So this one's a lot more drawn out. This is a lot more, as I said, very gentle in the sense of just trying to give you this pleasant, very relaxed state. So that way you begin to break the classically conditioned association of fear to the spider to one that is now more relaxed and pleasant. So that way the item doesn't evoke that fear any longer, but one of just relaxation in the sense that it no longer has an unpleasant reaction from you. Now, aversive conditioning uses counter-conditioning techniques in the sense of associating an unpleasant state with an undesirable or a maladaptive behavior. So you heard me make reference to this with alcoholism. It is possible in some circumstances where I don't know about how common it is nowadays, but people would, when going into therapy for alcoholism, it was possible for them to place something in the drink called an emetic, which is a drug that makes you get sick to your stomach. They would put that into an alcoholic beverage. And so anytime a patient would drink that alcohol, they would become just violently sick to their stomach. And so the whole point and goal behind it was get them to no longer enjoy alcohol, which they felt facilitated the addictive behaviors, but get them to have a very unpleasant response to alcohol to get them to break the habit. So ultimately what happens is when you see alcohol, which would be your conditioned stimulus, you have a conditioned response of nausea rather than a desire to drink it. Aversive conditioning has been used, for example, to get kids to stop biting their fingernails in some circumstances. Parents can put like Tabasco sauce under their kids' fingernails, for example. And so when a kid goes to bite their fingernail or to suck their thumb, they get, obviously Tabasco sauce, which is very spicy, very unpleasant for a kid. So they begin to associate that scenario with biting their fingernails or sucking on their thumb, so they no longer want to do it anymore. Now, with operant conditioning techniques, what the therapist is going to use is behavior modification as well, but this is going to connect in with aspects of reward and punishment. So they're going to reward for the desired behaviors, and undesired behaviors either are not rewarded at all or they're punished out of the person, depending. It is very telling, for example, the support that is out there for operant conditioning techniques when looking at the use of rewards for autistic children. A number of very not communicative and significantly socially withdrawn autistic children were successfully trained toward demonstrating far better social interactions by receiving reinforcements for their desired behaviors and taking away those reinforcements when the undesired behaviors presented themselves. So one of the more common types of operant conditioning techniques out there via the reward system is a token economy. You see these often in institutional settings. Therapists will try to create a setup where a patient can get tokens for exhibiting certain desirable behavior. And then once they've accrued a certain number of tokens, they can turn them in for various different privileges or treats or something along those lines. So it's very common for you to see those kinds of scenarios in hospital wards for psychiatric patients. Some therapists do use that in their practice. When they have a patient journal, for example, and there are demonstrations of them operating on desirable behavior, then they receive certain rewards and things along those lines. All right, real fast, let's move into cognitive therapy. And then after this, we'll start talking about the biomedical stuff. So cognitive therapy is trying to get people not necessarily to directly go after the behaviors. What cognitivists emphasize is the maladaptive thought processes. To them, it's the bad thoughts that cause the bad behaviors. If you didn't have the bad thoughts, then you wouldn't have the disordered actions. So what they do is they work to intervene in our responses, cognitively speaking, emotionally speaking, to life events to get us to view them in far more different lights. Okay, so you can look at it from this perspective here. I lost my job, so then the internal thought process is I'm worthless. I'm never going to be able to find a job that I like. There is nothing out there that I like, and so that ultimately can facilitate a development of depression. On the flip side of things, if you were to have far more positive take on what has occurred in a negative circumstance, like what cognitivists attempt to do, they would say, look, yeah, you lost your job, but your boss is not the best. They're not a very pleasant person, so you've avoided having to interact with them any longer. And ultimately, you deserve something better. Telling yourself that you deserve better is something that can be incredibly powerful. And that leads a person to not end up having a level of depression over something that would, in many respects, cause depressive episodes from people. Aaron Beck is one of the forefront or foremost cognitive therapists out there. His research with those who struggle with depression showed that there's a very strong ruminatory process there for depressed patients where they truly believe that it's not possible for them to ever be happy. Nothing will occur to make them enjoy their life. And so for Beck then, the ultimate issue was that these patients associated even the most mild failures to those connections with depression, that nothing they do is good enough, nothing they ever do shows that they are capable. And so for Beck, looking at mentalities of I can never be happy, you had to change those to recognize that how you perceive a life event very much impacts ultimately the actions that you operate on. And so what he would do is some pretty gentle questioning of those patients to get them and prompt them to ultimately try to better understand the maladaptive thoughts and how those ultimately end up impacting their behaviors. And so when cognitive therapy was used even further in research on depressed patients, they were asked to keep daily records accounting for positive things that had occurred in their day and ultimately how they as individuals contributed to the creation of those positive events. Those trained patients started to show lower depressive symptoms compared to other patients who didn't get pushed to focus in on the positive parts of their day. And so that to them demonstrated a pretty significant context of looking at the significance of evaluating maladaptive thought rather than just maladaptive behavior individually. Now, another form of cognitive therapy could be viewed in terms of stress inoculation training. Mike and Baum attempted to try to train people to ultimately focus in on those maladaptive thoughts that they have and restructure their thinking in situations that evoke stress from them. So, for example, what he would do for someone who struggles with regard to anxiety would be something along the lines of getting them towards something like this. Relax, the exam may be hard, but it will be hard for everyone else too. I studied harder than most people. I don't need a perfect score to get a good grade. So it involves that rethinking about a situation that evokes a stressful or anxiety-causing response from events that a person experiences in their life. It is possible for you to see combinations. So this would be a scenario of kind of an eclectic approach via cognitive and behavioral therapy. A lot of times you're going to see cognitivists attempt to take their effort and focus on thoughts and combine it with modifying behavior to reverse that kind of self-defeating cycle that is often present for those that struggle with mental disorders. So you get cognitive behavioral therapy. What this attempts to do is not only alter the way that people act, which is the behavioral component, but then ultimately how they think as well. And we'll get into a little bit more with that in class with one another. We'll talk about some guys, Albert Ellis, and we'll go a little bit more in depth on Aaron Beck as well. Let's talk about group therapy very quickly. So with regard to group therapy, this is when you are struggling with a disorder and you work together with upwards of 6 to 9 people who are struggling with similar issues. It's a way for an individual who feels often very isolated by their disorder to feel like they're part of something, to feel like there are others who understand what they're going through, who can identify with their struggles, so they don't feel so alone. It's very common for you to see clients benefiting from knowing that others have similar struggles, and they're not as alone as they think that they are. Family therapy can also be something that's of very significant value. Family therapy is ultimately looking at the family of a disordered individual as a whole unit. So what the point is behind that type of therapy is to guide family members, toward positive relationships with someone who is struggling with a disorder, helping them to improve on communication. It can facilitate enabling family members to understand what the disordered individual's thoughts are in circumstances. And it can also help to facilitate how the family of that person is affected and impacted by the maladaptive thoughts and behaviors that they operate on as well. So now we're going to move into biotherapy, and this is going to be, if we're not already making your brain swim, this is going to add another layer to that mix. There is an awful lot you're going to need to know in terms of the biological component, but make no mistake, we are going to make sure that you get a much more in-depth evaluation of this stuff in class. But for the purpose of making this so that way the video doesn't go to roughly an hour in length, with more in-depth evaluation of things, I'm going to go through it pretty briefly just because I know that I've already asked you to sit here for a pretty long period of time. Thinking back to the beginning of the video, we told you that biological therapy is going to work on the nervous system and some of its deficiencies or abnormalities via drugs or some other type of physiological procedure, like a lobotomy or ECT, electroconvulsive shock therapy. So let's talk about antipsychotic drugs. Antipsychotics are going to work as, let me just put myself right here, they're going to work as antagonists. If you remember back to Unit 3, we learned about these. Antagonists ultimately block the reuptake of a neurotransmitter. Agonists mimic the presentation of neurotransmitters. So what these are going to do is they're going to stop dopamine from flooding the brain. If you think about it, antipsychotics are often prescribed for schizophrenia, and we do perceive one of the major causes for schizophrenia to be an oversupply of dopamine. So it makes sense that these drugs would attempt to shut that off. It is possible to have combination drugs that also go after serotonin levels, like Zyprexa, Seroquel, Risperdal. Abilify also goes after dopamine and serotonin, although it does it in a little bit of a different way. And I'll talk about these drugs in a second. But antipsychotics are going to focus in on those dopamine receptors, regardless of whether it's just dopamine by itself or serotonin. It's important to recognize some of the major side effects to these drugs. There is a presentation of significant sluggishness. It's possible for a person to develop tics and other body movements that are quite involuntary. This side effect is called tardive dyskinesia. You can have a lowering of white blood cell count, which can cause ramifications for immune system functioning, among other things, and there can be significant weight gain to this. It's important to recognize that the more common forms of antipsychotics are like Thorazine or Clozaril, which are their chemical names are chlorpromazine and clozapine. But their box labels are Thorazine and Clozaril, and even Zyprexa, Seroquel, and Risperdal. These can all be diagnosed, well, I should say diagnosed, but they can all be used for manic episodes as well. Psychosis is a break from reality, and in manic episodes and manic states, it is possible for bipolar patients to have psychosis, and so as a result, it's not out of the ordinary for you to see those with bipolar disorder to be given antipsychotic medication. It's also possible for you to see it be diagnosed and used for those with depression as well. In your Out of the Shadows documentary, you heard the story of Andrew, the author who struggled with some just absolutely debilitating rounds of depression, and he makes reference to Risperdal in particular, and Zyprexa, that he is prescribed those meds as well. And so those can because of that serotonin component there, it would make sense for why it would be connected in with depression as well, even though psychosis isn't necessarily a common symptom of depression. Another type of biotherapy in terms of drug would be an antimanic. Okay, so this could also be prescribed to someone with bipolar disorder. So you would have the antipsychotics that are out there like Zyprexa, but an antimanic is going to connect more toward lithium, lithium or lithium carbonate, like Depakote. These are going to help an awful lot with stabilizing the mood. We don't know really why it is that lithium is capable of being able to do that and to work for people with bipolar disorder, but we do think that it has an ability to strengthen nerve connections in areas of the brain that help to regulate mood and thought and behavior. And so that's pretty much all that we can offer for the time being in terms of why it's successful in doing what it does. It's important to recognize that lithium is very powerful. You've been presented with lithium before on commercials from like batteries. So too much lithium can be toxic in certain levels. So it's very important that the individual prescribing the lithium to the patient is monitoring that amount, so that way blood toxicity levels do not get too high, because that can lend itself toward other very significant side effects. Now, with antidepressants, this you've heard me make reference to in earlier units as well. There are two different categories within antidepressants. We know that depression is very heavily connected or linked to serotonin. In some circumstances, we also believe that it connects to norepinephrine and dopamine. So again, that would explain why some antipsychotics can be used for depressed patients. So if it's an SSRI, that stands for selective serotonin reuptake inhibitor. That's only going to block the reabsorption of serotonin when it's been put out across the synapse. So this is a diagram, if you will, for an SSRI, like Prozac, Zoloft, Celexa, Lexapro. Those are very commonly prescribed SSRIs. An SNRI is going to block the reuptake of serotonin and norepinephrine. This more commonly is seen in the drugs Effexor or Cymbalta. These are SNRIs. You'll typically see results within 2 to 4 weeks, but that's an important thing to recognize for those that are struggling with depression. If you are having suicidal thoughts and having difficulty being able to get yourself to a point where you can get out of bed, 2 to 4 weeks is a long time. And there's no guarantee that that drug that's prescribed is going to be the right balance in terms of your neurochemistry, that your depression is caused by only serotonin, serotonin and norepinephrine, serotonin, norepinephrine, and dopamine. So there's a lot of factors that can play into that. So that's why depression, in and of itself with regard to medication, therapy-wise, it's good for it to be coupled with some other type of psychotherapy along with the medication. Anti-anxiety drugs like benzodiazepines, you're familiar with them as Xanax or Valium, Librium or Ativan are also common presentations of those, or box labels. What anti-anxiety drugs are going to do is they lessen the response that the brain has to stimuli that signals to us kind of that fight or flight response of punishment or frustration. Okay, and it's very common for you to see results within a week, but it's important to recognize that these drugs, benzodiazepines, are going to be prescribed for limited use. They're not going to be like a very consistently, continually what's the word I'm looking for here? I can't think of it. But ultimately, they're not going to be prescribed refill. There we go. Tip of the tongue phenomenon, guys. They're not going to be given like multiple different refills right off the bat. You have to watch these very carefully when they're prescribed, because it's possible for a person to develop physical dependence to them and become addicted to them. And so they have to be very carefully monitored, as does bipolar medications with lithium. Major side effects can be drowsiness. It's very common for you to see that sense of just being very, very tired for those that are given these drugs. They struggle to be able to concentrate because of a sense of lethargy in being tired. And as we said, it's also possible for there to be some physical dependence that can present itself as well. Now, other types of biotherapy are basically physiological procedures. So that would be ECT, electroconvulsive therapy, electroconvulsive shock therapy. Let's move that out of the way for a second so you can get that written down for yourself. ECT is used only for cases of severe depression. And this is another one why we're not entirely sure why it seems to work. But what it does when you place these electrodes on the temples of the scalp, and you anesthetize the person and you use electric current through the brain, multiple times a week for several weeks, it seems to do something by resetting the hypothalamus that results in readjusting a person's hormone levels. We don't know if that's what helps to kind of balance out or address the symptoms of depression, but that seems to be some kind of connective physiological marker in terms of an impact for ECT. It does have fairly immediate results in terms of mood-altering effects. And there's always been kind of this concern of what does it do to a person's memory? There have been kind of these conceptions out there that, if a person goes through ECT, basically what it does is it's going to wipe out all of their memory. When you use today's methods, there's very small or limited amounts of impact on a person's memory when they use ECT. Unfortunately, though, that hasn't stopped kind of that misinformed understanding of ECT that's present in the public still. All right, so then the last piece that we're going to take a look at is psychosurgery. You're going to see this very rarely, where people are going to undergo actual surgery to the brain to offset a mental disorder. So the most famous kind of psychosurgery out there is a lobotomy. Walter Freeman in particular made it very popular and widely known in the 1940s and 50s with his landmark ice pick lobotomy, where he would take an ice pick up a person's eye socket. They would be anesthetized, but he would do that and go up through the eye socket to the frontal lobe at a particular angle, and ultimately take a hammer to tap it up there into the brain, and then ultimately maneuver it around back and forth to sever the brain tissue and connections from the frontal lobe to the remainder of the brain. Lobotomies used to be used on people who were perceived to be violently mentally ill. It was seen as a way to make them docile, basically, to be more calm. It has major lasting side effects to it. Permanent lethargy. There is very minimal level of energy, very impulsive personality, and a significant amount of immaturity that's present. Because if you think about what the frontal lobe is responsible for, personality development, judgment, planning, impulse control, emotion control, it makes sense that all of those side effects present themselves as such. Rosemary Kennedy's circumstance is one of the most famous connected to lobotomy. She is the sister of former President John F. Kennedy. When she was 23, she was sent to receive a lobotomy. Rosemary had some difficulties. She had some developmental delays. She had been denied of oxygen at birth. And so as she was growing up, there were some demonstrations of some developmental issues. She had some emotional outbursts. And her father perceived that as a possible threat to his desire to have one of his sons become president of the United States. And so Rosemary was lobotomized. Unfortunately, the lobotomy did not go according to plan. It was botched. And so she was left with the mental capacity of a toddler for the rest of her life, and was institutionalized and basically kept from her family for years and years and years on end, as just this like awful secret that the family kept to themselves. So her story is one of the more famous of people who have been lobotomized, but it is very, very, very rarely done anymore because of what we know of what can happen to it, to a person because of it. So it's a pretty rare demonstration that you'll see this presented in any kind of circumstance. So I've talked an awful lot. This is a very long video. I appreciate your level of patience and thoroughness in making sure that you've got all of this info down. The nice thing is we've only got one more video after this for this unit, and it will be fairly brief, all things considered. I promise. Thanks for paying attention, guys, and I will see you in class.